Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gil Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gil@eapen.info. My guest today is Professor Wael Asaad, who's Associate Professor of Neuroscience and Neurosurgery at Brown University. He is also the Director of Functional Neurosurgery and the Epilepsy Program. Welcome, Wael. I want to start with one of your papers, Deep Brain Stimulation, Targeting the Fornix of Mild Alzheimer's Dementia. You say in this paper, given recent challenges in developing new treatments for Alzheimer dementia, AD, it is vital to explore alternate treatment targets, such as neuromodulation for circuit dysfunction. Before we get into the detail, what exactly is deep brain stimulation?
Sure, yeah. So, deep brain stimulation is a well-established therapy for movement disorders in particular, such as Parkinson's disease, where it's most often used, but also for things like essential tremor. We also use it occasionally for intractable psychiatric diseases, such as OCD, although we also do some other procedures for that. And so it's basically just a method for putting electrodes in the brain to deliver electrical stimulation that can modulate the activity of brain circuits. And so it's really to be contrasted with chemical neuromodulation, which is what you do whenever you take a pill that affects brain function. And the advantages, of electrical neuromodulation are that you can target it directly to a circuit and modify that circuit irrespective of sort of the natural boundaries of chemical mediators. If you take a drug, the circuits, then the neurons that drug works on, really sort of just depend on where evolution put them. Whereas, if we have a knowledge of the circuits we're trying to modulate, we can anatomically target our therapy. The disadvantage, of course, is that, for something like deep brain stimulation, you have to actually do neurosurgery. And even though by our standards in neurosurgery, it's relatively minimally invasive and, relatively safe, obviously there are always risks associated with it. So, but the advantage is that with neuromodulation, you can often do things that you can't do with medicines.
So in this case, while the electrodes are actually going into the brain, so you actually have you're surgically inserting the electrodes?
That's right. So we, typically a pair of electrodes, one on each side of the brain into the relevant circuit, and everything's implanted under the skin. So nothing is, visible to an outside observer. And we tunnel the electrodes to a battery that's typically, we call it a battery, but it's really kind of a little more fancy than that. It's a pulse generator that is implanted underneath the skin in the chest, kind of like a pacemaker would be. And the wires run under the skin to the electrodes, in the head. And this procedure can be done, awake, which is the sort of the standard way to do it. It can also be done using intraoperative image guidance, using a CT or an MRI. But it's remarkable when it's done awake because, the brain doesn't feel pain directly. And if you numb up the skin, you can go and put it in there and you find the circuit, you test the stimulation to make sure that it's working the way you like. And patients, are very, very cooperative and eager to have this procedure done in many cases. And it's great to see its effect immediately in the operating room to know it's
Right.
going to work before you close
Yeah, and
everything up.
Alzheimer's, after many, many disappointments, we haven't been really able to do anything from a chemical intervention perspective, or do very little, I should say. And so this is going in that direction, right? To see if we can actually approach it differently.
Yeah, so we were part of a multi-center trial. We were one of the sites doing, testing deep brain stimulation of the memory circuits for Alzheimer's disease. And what we, were hoping to do was to modulate that circuit so that just like in Parkinson's disease, when you do deep brain stimulation for Parkinson's disease, you're not really changing the underlying course of the disease as much as you are just kind of improving the symptoms, and so the person can function better, even though unfortunately the disease keeps progressing. We were hoping that at least that might be the case in Alzheimer's, where even if we couldn't change the underlying course, and it's not certain that we would or wouldn't be able to, but even if we couldn't, that at least we might improve memory function. And this was based on, this whole trial was based on the work of a well-known neurosurgeon in Toronto named Andres Lozano, who found that in a small group of patients, when he was, trying to stimulate a nearby area, that stimulating this specific memory structure called the Fornix, which leads to the hippocampus, which is kind of a core structure in the episodic memory system, that when he inadvertently stimulated this circuit, patients had a sudden recall of, with great clarity of distant events in their lives that, they may not have thought about for a long time, which gave him the idea that maybe if we modulate this circuit, we might be able to boost memory, again, in analogy to Parkinson's disease, where we boost the right circuit to help,
So you talk
the
about
symptoms.
mild Alzheimer's dementia. Does that imply that you have to, if you were to be successful here, it really has to be early?
Well, we feel that it's probably most advantageous to try and intervene early, just because there might be the best chance of changing the course of that person's disease, at least in terms of symptomatic control. But, it's not clear that that's necessarily the best way to do it, but it probably makes the most sense for where to start with this.
So what did you find? So this study, if I read this correctly, 42 patients in the study?
That's right. So, we enrolled, I believe, 7 of them here, and it was a study across 8 different sites. And, it basically it was a small study, and it was designed mostly as a feasibility study to assess the feasibility and safety of this approach, because nobody had ever really, targeted the circuit before with deep brain stimulation. So we had to make sure that it was just a reasonable thing to try. And what we found was that it's indeed just about as safe as any kind of, DBS procedure we would do. It didn't seem to pose any special risks from that perspective. And then it did have some positive results in terms of, boosting the metabolism of key parts of the brain that might be related to Alzheimer's. But, it wasn't clear that we were seeing a therapeutic benefit yet. So there's actually a new advanced trial. The advance was the name of the trial. And so there's a new advanced trial just getting started, over the last few months, where we're enrolling, along with a bunch of other centers, a larger number of patients, testing stimulation to see if there's, more of a signal of benefit, and also trying some different stimulation.
And so the first trial, you established safety, but efficacy was unclear. Larger trial is about to start. How long is the stimulation? Is it multiple procedures, or what is sort of the modality?
So, well, the stimulation itself is ongoing, and something we call open loop, meaning it's not really responding to the brain to stimulate. It's simply stimulating as a pacemaker would, sort of in a continuous, manner. We do have, one type of closed loop stimulation that we use for epilepsy, which is very exciting, where you actually have a device that records brain activity and stimulates in response to that. And in animals, there are a lot of animal studies that show that if you do that sort of closed loop stimulation, you can certainly boost memory, by stimulating the circuit in that fashion. But the technology for humans is really quite limited still. And so the most proven technology, the best technology we have right now for stimulating circuits is sort of standard open loop deep brain stimulation, which is what we're trying here.
So you mentioned certain circuits, memory coming back. So
So do you have a specific location that you're targeting, or it's more general?
No, so for this, we're targeting a structure called the fornix, which is related to the medial temporal lobe. It's the output for the hippocampus, which is a critical structure in the formation of memories, and it is part of a circuit called PAPES circuit, which goes through some frontal cortical areas, and so it's thought that this circuit is really responsible for laying down new memories. And so this is just one way of stimulating that circuit. It's also possible to stimulate the circuit by putting electrodes directly into the hippocampus, and this is just one of many possible strategies.
So if you're successful here, Wael, will that be, epilepsy and Alzheimer's obviously very different. In Alzheimer's, do you think you will be able to sort of reestablish the memory and the normal functioning of the brain?
It's hard to know. I think that ideally, I think that our goal would be simply to boost memory a little bit, and so that patients can function a little bit better than they do, and that they would otherwise without it. That's sort of a minimal goal. But a more optimal goal would obviously be to slow down the disease or change the course of the disease. So it's not clear what's going to happen. I think first we just want to see some signal of benefit, whether that represents a symptomatic benefit or truly a disease modifying benefet. That we'll have to figure that out later.
I don't know a lot about Alzheimer's, but I guess at some stage the patients, even the short-term memory is greatly affected, right? So is that the case that they can really function? They just just forgetting even very short-term memory aspects?
Well, as the disease progresses, so it's not just the hippocampus that's involved, it's the temporal lobe, it's the frontal lobes, the parietal lobe. And so, as the disease progresses, more functions, including things like working memory, begin to become involved as well. I think that it's really an open-ended question, which is why we study it, which is why that there's a formal trial to investigate the possibility that we might provide.
And so you said this trial is just starting. So how long do you think it will be?
So we're hoping to enroll patients over the course of the next year, and then each patient will be followed for a minimum of 1 year. And we'll see how it goes.
You do have sort of a control group here that who will go through essentially deep brain stimulation, even though they don't have any disease state.
Well, so actually, deep brain stimulation offers a good opportunity to perform a sort of control called a delayed start trial. And so what happens is that you have two groups of patients, both of whom are implanted immediately, and one of whom is turned on. The other one gets turned on at a later time. And so what you can do is, number one, you're offering every patient the possible benefit of turning it on. But from a scientific perspective, what you're doing is you have one group that may continue to progress despite the implantation because they're not turned on, and then another group that hopefully does better because it's turned on. And patients are randomized to one of those two groups. And that's really the only way to be able to have a valid comparison, because it might be that, so for example, in Parkinson's disease, there's something called a micro lesion effect, where just putting the electrodes in can mimic stimulation to some extent and cause change in their symptoms. And, while we don't expect that same sort of thing necessarily to happen here, there's still this issue of, well, is the surgery itself doing something, or is it the stimulation that's doing something?
Do you see any sort of preventative type therapy in the future? For instance, if a person is at a high risk of developing Alzheimer's, but doesn't show any symptoms today, do somebody like that benefit from early deep brain stimulation like this?
Well, I think practically speaking, we have a good example in Parkinson's disease, actually, because we have, good evidence that the earlier you get deep brain stimulation in Parkinson's disease, the better you do. And yet it's very difficult to convince patients who are in the earlier stages of their disease to have brain surgery for understandable reasons. And so most patients wait until their disease is to the point where they're really not doing well on medical therapy. And then they get the DBS, the deep brain stimulation. But we know from studies, like I said, that that's actually suboptimal, that they would have done better for longer if we had implanted them earlier. And so I think practically speaking, it's unlikely patients are going to go for an invasive procedure like this early on. But I think that, it's something to consider when we get to the point where you can maybe predict these diseases earlier before, someone is symptomatic. If there's a known treatment that's, disease modifying or at least, symptomatically beneficial, then I think that, depending on the invasiveness in the patient, there might be some consideration of going forward with a procedure like that.
I mean, I don't know a lot about this, Wael, but there's been a lot of talk about embedding the chip in the monkey playing video games and so on. So are we going in a direction where this type of procedure might become either the risk in the procedure is pretty much removed completely, that patients should be more willing?
Yeah, I think that's probably true. I think that, it's going to come down to what the perceived benefit of the procedure is. I mean, if there's an invasive procedure, and then now we're talking not necessarily about, disease prevention or disease alleviation, but, even, potentially cognitive enhancement and things like that. If there's a perceived benefit that's very, very significant and, the procedure itself is known to be less invasive or at least, less risky, I know that the Neuralink stuff that, Elon Musk is involved in is, one of the advantages is they're using very, very fine electrodes that are much smaller than, what are typically used in these sorts of applications for humans. And if, and they're using robots to help guide the implantation. And so if all these things are, truly beneficial in the sense that risk is significantly reduced and the benefits are increased, then I think that there will probably be growing acceptance of this sort of thing. I think that there's kind of a bias against, surgical procedures compared to chemicals, drugs, because, people feel like, somehow they're being, violated to have, it is, kind of a potentially a gruesome looking thing or kind of a scary looking thing or, something, that can turn people off. But at the same time, in terms of what you're actually doing to the brain, you can, in a certain sense, be a lot more specific than you can be with drugs. Again, because you can target the treatment, the device to very specific circuits. And in animals, again, the technology for modulating neural circuits in animals is quite a bit ahead of what it is in humans. But that involves, potentially inserting genes with, adenoviruses that can make neurons responsive to light. And you can very, very precisely control which neurons are active or inactive. And so I think that it's, almost inevitable that in humans at some point we'll have that same technology. And the potential benefits are really tremendous.
Yeah. So since it's a sort of an electromagnetic chemical system, is there a possibility we can have non-invasive techniques? Like, is magnetic stimulation a possibility?
So yeah, there is transcranial magnetic stimulation currently, and that's being used for things such as, depression. The psychiatrists use that quite a bit for intractable depression. It's being studied for a lot of uses. There is a new technology called focused ultrasound, which can be used to, you can modulate the brain in a couple ways. You can, insert electricity into a circuit and cause the circuit to be modified in its function that way, or you can create a lesion. A lesion is basically like a disconnection, right? And so there's a new technology called focused ultrasound where you can actually create a disconnection, which can be beneficial. It's kind of like a double negative patch for, a pathologically hyperactive circuit or something like that. So you can create a disconnection by focusing ultrasound through the intact skin and skull. And with lower frequency ultrasound, you can actually potentially not just produce the disconnection, but actually drive the circuits in different ways. And so, the problem with some of these technologies is that, for any treatment that needs to be ongoing, for instance, the focused ultrasound device, is a big device, several $1 million that sits inside of an MRI scanner. And, it's not something you can walk around with. But the principle of it, may be something that over time is, can be shrunk and, sort of applied to a hat that you wear.
Right, right. Yeah, I mean, those engineering problems will be ultimately solved if it is efficacious, I guess. So you mentioned Parkinson's disease. You have another paper, Rapid Motor Fluctuations Reveal Short-Timescale Neurophysiological Biomarkers of Parkinson's disease. You say identifying neural activity biomarkers of brain disease is essential to provide objective estimates of disease burden, obtain reliable feedback regarding therapeutic efficacy, and potentially to serve as a source of control for closed-loop neuromodulation. So, if I understand this correctly, there are some sort of diagnostic capabilities here. Even
Yeah, and I think that's actually something that's underappreciated about invasive neuromodulation devices, is that one of the great limitations in treating neurologic disease is having an accurate estimate of how bad the disease is. Especially certain diseases that fluctuate over time, and epilepsy is a great example, right? I think that if somebody has epilepsy, for instance, and they come to their neurologist and say, I think I've had 13 seizures in the last month, and but I'm not totally sure. Some types of seizures are very difficult for people, even the patient or their family, to be really aware that that's event is even a seizure. And so and then the neurologist listens to the patient and tries to make their best guess as to how bad things are, if things are better or worse than they were the prior month before the medication adjustment, let's say. And so then the neurologist has to use this imperfect information, because the patient's own account is limited by the complexity of the disease and the recounting of it. And so the neurologist makes a best guess and hopes that the new change in medication actually makes their life better. This is also true in diseases like Parkinson's disease, which fluctuates quite a bit. And so having some direct biomarker of what's going on with the disease can actually really help guide therapy, regardless of whether or not the device is actually stimulating, just its ability to record neural activity. And so in epilepsy, we have this device called, the trade name is NeuroPace, the generic name is responsive neurostimulation. And it's kind of like a brain defibrillator. It's designed to detect a seizure, and upon detection, deliver stimulation to try and break up that activity so the seizure doesn't progress. And what we've learned from that experience is that simply having access to recordings of seizures and simply having an objective record of seizure occurrence is actually very, very useful on its own, regardless of whether or not the stimulation improves their seizures, which it does, fortunately. But even before that, just the objective record of their disease is very, very useful. And so our paper is sort of looking at, whether we can understand what patterns of neural activity in Parkinson's disease are related to fluctuations in that disease state.
And so if I understand this correctly, so you're using some sort of machine learning techniques here, right? So you're getting a lot of data, and what you're looking at here is using a machine learning technique could identify perhaps the state of the disease and the progression.
Yeah, so it turns out that in Parkinson's disease, it's a very interesting disease, right? It's not so much a disease of motor function at its core as much as it is a disease of plasticity in a funny way. And so it turns out that patients with Parkinson's disease are able to, at different times, at different moments, make movements that are more or less effective, more or less normal, and so what we did was we basically had patients perform a task where they moved they moved a little stylus, a little controller to try and track a target moving on a screen. And as they did this, we used machine learning to estimate how good their movements were. And then we looked at neural activity recorded from their brain while they were doing this task. And we used another layer of machine learning to try and understand which patterns of neural activity corresponded to those moments when they were doing relatively better or relatively worse. And so in that way, we were able to identify different patterns of oscillations that corresponded to better or worse motor performance. And what was interesting was that we found that these patterns really varied quite a bit from person to person and location to location inside this small part of the brain that we were recording. And so it may be that ultimately, to have the best therapeutic efficacy of therapies like deep brain stimulation, it would be good to modulate them to the person's level of disease at that moment. But in addition, that the way in which it's modulated might depend on their particular pattern of brain oscillations that are related to the disease.
That's fascinating. So what do you think the primary reason is that it has such high variation both in location as well as intensity? Is it just the disease progression level, or some other factor?
Yeah, I think it's probably a couple of things. I mean, I do think that, at a microscopic level, brain circuits are different in different people, and you wouldn't expect things to be exactly the same from person to person. But I think that a lot of the variation might be explained by the disease subtype. So Parkinson's disease actually has several subtypes within it. There's a certain form called a tremor dominant form. There are non-tremor dominant forms that include other symptoms such as being slow or stiff or unsteady in your gait and posture. And so depending on the subtype, that might be related to the pattern of activity we're seeing. And each patient, expresses a different degree of each subtype. It's not that they're mutually exclusive, but, and so the degree to which different patients have these different features of Parkinson's, it's kind of a syndrome, even though it seems to have the same pathological underpinning, which is the loss of dopamine neurons. The manifestation of that seems to be quite varied across individuals. And so we think, and we did show in that paper, that it seems that some of the variability at least can be explained by the subtype.
Do you see any evidence that when the brain realizes there is an issue, it tries to co-opt some other circuit for counteracting in any way?
Yeah, I think that form of compensation is well known, and it's a question as to whether or not, that some of that is under conscious control, that you just find a new strategy trying to achieve the same thing. That's in a way that's using bypassing the pathological circuit for a totally different circuit. But at a smaller level, I mean, I think that, a good example in this again is with epilepsy, where patients may have temporal lobe epilepsy and memory on one side is severely affected because the temporal lobe is where memories are in part formed, and the epilepsy hurts the function of those circuits, and you find that their memory functions are shifted so that the other side may actually take on more of that role.
Yeah, so because there is a lot of variation, I don't know if it's possible, but does the data show diagnostically where the patient might be from a disease progression perspective, or even the subtype of Parkinson's that the patient might be suffering from?
Yeah, absolutely. There are definitely some good reports that indicate that the neurophysiological activity might be related to the level of disease, how far along they are, how severe their disease is. There's a good paper looking at the subtypes and how different oscillations might be related to oscillations in different parts of the basal ganglia, which is a structure in the brain that's involved in Parkinson's disease. So there's definitely evidence in that, for those things. And we have our own work, related to that as well that we're currently, preparing. And so, I think that there's a lot of evidence that we should be able to learn a lot about the disease by looking at neural activity.
And so deep brain stimulation is used for Parkinson's too, right? And how effective has it been? Has the effect been temporary, or what's the status quo on that?
So there's great evidence, very high quality evidence in well-designed controlled studies that patients who, reach a certain point in their Parkinson's disease where the medications are not optimally treating their symptoms, that when they get DBS, they do better, in terms of just overall quality of life and function in life, than patients who didn't get DBS. And so there's very good evidence that it's a good therapy. It's approved by all insurance, because it's well established. So it's not, it really shouldn't be controversial. But that being said, there are still, neurologists out there and other, doctors, primary care doctors who have, a funny sort of attitude towards it, again, because it's invasive brain surgery. And a few years ago, and I think this person has come around, but a few years ago, a neurologist came up to me once and said, I think, deep brain stimulation is barbaric, and so, I didn't say anything back at that moment, but my thought was, well, I think suboptimally treating patients who could be doing a lot better is barbaric, right? So, but I do think that there's some of that attitude remaining, but, just like all revolutions in science, science, sort of progresses when, people who hold an older attitude sort of leave the field, right? And new people who are more open to new ideas kind of, enter the field. And I think that's happening.
Yeah. I remember seeing something where maybe I misunderstood it. The DBS in the case of PD, effect was very tactical, that once you remove it, the patient seemed to go back to where they started.
So yeah, for the most part, we do believe that it's kind of an ongoing therapy that when you discontinue it, so if you turn the DBS system off,
Yeah.
their symptoms will return. There is a little bit of evidence that if you compare patients who, let's say are at a certain stage of their disease and you look at their tremor, resting tremor is one of the cardinal symptoms of Parkinson's disease. And if you look at patients who've had DBS for a long time, many, many years, and you turn off their DBS and then examine them a week later and say, well, how bad is your tremor? And presumably by that point, the DBS is, fully worn off. Usually it wears off in the course of minutes or maybe an hour. And so you look at their tremor, a week later, and you compare that to patients who are at the same stage of disease, who never got DBS, who were at the same stage initially, before, when the other group got DBS. And it turns out that, their tremor is, apparently somewhat improved. I mean, it's just one report, but that would be potentially evidence of a disease-modifying benefit, that the progression of tremor was actually slowed down.
Yeah.
So, there's some hope that might be true to some extent, but we don't have a lot of evidence to suggest that DBS is doing something more than just temporarily treating symptoms as it's active.
Do we currently have any chemical treatments for PD?
Oh yeah. So the primary, the first line treatment is dopamine replacement therapy. So, the primary pathologic deficit or, pathologic problem in Parkinson's disease is a loss of dopamine neurons in the midbrain. And, there's this common perception that, dopamine is, kind of like a rewarding neurochemical or, there's a movie called Dopamine, which links it to love, and the feelings of love. And I think that it's a bit of misunderstanding because dopamine is actually involved more in reinforcement and in reinforcing behaviors. And without dopamine, what seems to happen is the system that produces movement is sort of uncalibrated and sort of reverts to, slower, less effort, less vigorous movements.
Yeah.
And so if you just replace dopamine, you can regain some of that function. And that works for a while, that can work for, a few years, let's say. And then if the disease progresses to the point where dopamine isn't providing the benefits it used to, that's a good spot where DBS can help. But like I said, there's evidence that, doing DBS even sooner is actually even better.
Yeah, I wondered, have there been any trials that looked at sort of a combination therapy, both DBS along with other things?
Yeah, so DBS in combination with dopamine therapy is pretty standard. And the trials that looked at early DBS, that the DBS was in combination with dopamine therapy. So I think that in those cases, it's really, use every tool you have in the toolbox to really try and improve somebody's life.
Right. Yeah, so I want to finish up with one of your book chapters, LITT for Intractable Psychiatric Disease. What's LITT?
Oh, so LITT stands for laser interstitial thermal therapy.
Oh.
And it's a relatively new technology. It's very neat. And what it involves creating a disconnection, a lesion like we talked about, but in this case using a laser. And so you insert a laser to a certain target in the brain that, corresponds to a hyperactive circuit and a certain pathology.
Yeah.
And using an MRI scanner, so this all happens in an MRI scanner, you can actually look at the temperature that's coming out of that's in the brain that's a result of the laser. And you heat it up until that temperature is sufficient that you've caused the disconnection you want to create. And you can watch that in near real time, on an MRI scanner. So it's an MRI guided procedure. And it's very, very precise.
Yeah.
And it's one of the therapies that, we can use for instance, for, obsessive compulsive disorder. The other therapy would be deep brain stimulation. And of course, these are not just your run-of-the-mill cases of obsessive compulsive disorder. These are, very, very severe, medically intractable cases where the person is debilitated, unable to, perform routine daily activities in much of any sense.
Yeah.
And, what we're able to do is modify the circuit that's related to an area of the brain called the orbitofrontal cortex and the ventromedial prefrontal cortex. And those circuits seem to be hyperactive in patients with OCD.
Yeah.
And so these patients who failed every other therapy, in some cases they've even failed, electroconvulsive, therapy, electroshock therapy.
Right.
And so, once they've failed all those other things, unlike in Parkinson's disease where we think of DBS as, potentially a relatively earlier line therapy, in psychiatric disease, it's a later line therapy. And so, it's patients who are very, very severe. And typically, they fly from all over the country to one of a few referral centers, of which we happen to be one, to have this procedure done. And so in general, the laser procedure is just one more way to modify that circuit, the activity of that circuit. But it's a new technique, and it's very, very precise. We used to do it with gamma knife, which is a technique that involves giving focused radiation.
Yeah.
This involves inserting a laser catheter into the brain rather than doing everything from outside the brain, but it allows us much more precise control of the lesion itself, which we think is safer and perhaps more effective.
So is the way to understand it, so OCD, perhaps an overactive brain, and so with lasers and thermal effects, you are sort of disconnecting some circuits. Is that the way to understand it?
Yeah. So the orbitofrontal cortex, for instance, can exert its influence on the rest of brain activity through a variety of different pathways. And what we're doing is disconnecting one of those pathways in order to lessen its influence. And it's remarkable in that we often think about procedures like this in the context of frontal lobotomies, which were a very controversial procedure back when we didn't have any good medications or good treatments for psychiatric disease.
Yeah.
And those procedures were very dangerous and very debilitating. Patients' lives were changed quite dramatically and not infrequently for the worse. And so, what this is, this kind of psychiatric neurosurgical procedure is quite different from those old procedures. It's much, much more targeted. It's really based on a better understanding of the underlying science. It's performed, in order to perform these procedures, I don't make the decision myself whether a patient should get this procedure. We have a committee, and that committee includes, psychiatrists, obviously, neurologists, ethicists, neuropsychologists. And so it's really kind of a group decision for the most extreme cases. And, the other perspective I would have on this sort of procedure is that, in epilepsy, if we could identify a part of the brain that's causing epilepsy, and I were to put a laser in and, zap that area and take care of that area so it's not producing seizures anymore, nobody bats an eyelash, right? I mean, that's very standard. Yeah. And I think we have to think about psychiatric disease in the same way. It's a circuit in the brain that's active in a way that's maladaptive, that's preventing this person from, getting on with their life in the way that they would like to. And it's a brain-based disease that we have a brain-based intervention to help. And I think that, there's this, negative connotation for psychiatric neurosurgery, that's related to its kind of a, unseemly past, some would say.
Yeah, and I would imagine we are talking about an exceptionally small area, right?
That's right. Yeah.
It's going to be. Yeah.
So it's fairly small, the target region is, under, just a few millimeters in size, really.
Right. And I mean, it's fascinating that we can pinpoint, the affected area with a lot of technology now. But has there been any sort of unintended consequences of something like that in any other function?
So that's a good question. And we've been studying this because to a first approximation, most of these patients who get this procedure don't report any cognitive problems or any, real changes in their emotional state. They really just seem to have a benefit in their ability to, function, with reduced, symptoms of their disease. Yeah. But really we would expect that there's got to be something subtle that's changed, and that could be for better or worse, just like in some cases of epilepsy, for instance, if you use a laser to ablate the hippocampus that's causing the seizures, sometimes memory improves because what you've done is you've taken a faulty piece of the circuit out of the way, and the intact parts can function better. So, but we would expect that there's some kind of change, in their cognition or in the way that they solve problems, or something should be different other than just simply their disease, just because of the way the brain works. And so we're looking carefully at those things, but fortunately we haven't seen, any significant evidence of, cognitive decline or anything like that after a procedure like this.
Yeah. So in conclusion, while you have done a lot of work in this area, chemical intervention of the brain has been suboptimal, to say the least. You have to first get in there, and it's more of a hammer than a precise technology. So it seems like there are a lot of opportunities here. If you look forward 5 years, what are the areas that you are most excited about where we could actually make significant improvements?
Yeah, I'm looking forward to having, more capable devices that are able to process neural information. For instance, the processing that we did in that paper, using machine learning, no current implantable device in humans has the capability to perform those analyses online.
Yeah.
And so, it would be ideal to have systems that can, analyze brain activity at a higher level and respond to that activity in very precise ways that, very precisely treat symptoms, not just by putting the stimulator or whatever it is in the right circuit, but actually in a way that's time locked to the appearance or severity of symptoms. And so I think that there's a lot of possibility there. And in addition, I think that we might be able to harness brain plasticity in that way to really help the brain kind of unlearn bad patterns of activity, not just sort of treat them, in the moment.
Right. So something like PTSD.
Yeah, exactly. For something like that, or even in Parkinson's disease, I think there's a room for, applying brain plasticity to generate better movements.
Yeah. Excellent. Yeah, this is exciting research. Wael, thanks so much for spending time with me.
My pleasure. Thank you for having me.
Yeah, good luck with.
This is a Scientific Sense podcast providing unscripted conversations with leading academics and researchers on a variety of topics. If you'd like to sponsor this podcast, please reach out to info@scientificsense.com.